Okay, good morning, everyone. Thank you for tuning in for today's session of Breakfast at UMHealth. My name is Fadhilah. I'm a neuro-ophthalmologist from the Department of Ophthalmology. Today, we are going to have two presentations. The first one is from my department, and the second one is from the Department of Psychological Medicine. So, Dr. Lim Yi Wen is one of the registrars in my department, and she will be sharing with us 4 unusual cases of isolated third nerve palsy. So just a little introduction. So basically the third nerve or the oculomotor nerve controls the eye movement, the elevation of the upper lid, as well as pupillary constriction. And this nerve can be paralyzed by many etiologies. Okay, so traditionally these etiologies were loosely divided into either medical third or surgical third. And knowing the anatomy of the nerve, we know that the changes in the pupil are very crucial for us to pay attention to. So therefore, we should call it either pupil involving or pupil sparing third nerve palsy. But the changes in the pupils are not exclusive to this terminology only, and there is a lot of overlap between the two. And there could even be a mismatch between the presentation and the causes as well, right? So it's very important to recognize this condition. So let us pay attention to what Dr. Lim Yi Wen is going to share with us today, okay? So Dr. Lim, you may share your slide. You may start.
Thank you, Prof. Fadhilah, for the kind introduction. And good morning, everyone. I'm Evan, the 4th-year master trainee in Department of Ophthalmology. And thank you for joining us this morning for this morning webinar session. Like what Prof. Fadhilah has introduced to us, third nerve palsy, which is also known as the oculomotor nerve palsy, is not uncommon. And I believe some of the audience here did encounter or even manage a case or two before this. Unlike isolated third nerve palsy, when third nerve palsy presents together with other neurological deficit or together with multiple cranial nerve palsies, the site of lesion is a little easier to be localized. Here, we are going to share with you 4 cases of isolated third nerve palsy under our care, and how are we facing the challenges into diagnosing and recognizing the etiologies of them. So for this upcoming 20 minutes to 30-minute session, I'll walk you through some basic concept and anatomy of third nerve itself, followed by a little on epidemiology and etiology causing third nerve palsy before we move on to interesting case-based discussions. Well, let us start off with this basic anatomy of third nerve. Third cranial nerve has 2 major components, as I highlighted here. The first will be outer parasympathetic fibers, and second, inner somatic fibers. What we can see from this picture over your right-hand side, the outer parasympathetic fiber actually lies dorsally and peripherally. Its main function is to supply the ciliary muscle and the sphincter pupillae, causing pupillary constriction. Whenever the blood vessels on the pia mater, which supply the outer parasympathetic fiber, get damaged by compressive lesion, being aneurysm, any possible intracranial mass, or even hemorrhages, can cause dysfunction of sphincter pupillae, and hence a dilated pupil will be observed. This is what we call a pupil involving third nerve palsy, which was previously broadly known as a surgical cause of third nerve. What about inner somatic fibers? As the name suggests, inner, so this fiber is actually run along the inner area of the third nerve, and it is supplied by the vasa nervorum and can cause damage by ischemic changes, mainly by medical cause. Inner somatic fibers supply most of the extraocular muscle, being the superior, medial, inferior recti, as well as the inferior oblique, together with levator palpebral. So any damage caused by ischemic changes or vasculopathic cause can cause inner somatic fibers damage, and hence giving rise to ptosis as well as limitation of extraocular movement. In this case, pupil is always spared, meaning that you do have a normal pupil examination, and hence we are calling this as pupil sparing third nerve palsy, which was previously well known as a medical cause of third nerve. Like what Prof Fadhilah has told us earlier on, pupil examination is extremely crucial for us to determine whether this is a pupil involving cause of third nerve or pupil sparing third nerve. Have a look at the picture on your left. What we can see here from the uppermost picture, there are two normal pupil size equal. So for the down one in oculomotor palsy, what we can see is the right eye pupil appears to be dilated and the size of the pupil both eye comparably is unequal. This is what we name as anisocoria. So pupil involved in oculomotor nerve will get you a dilated pupil due to the impact of pupil constriction. Moving on again to this. This is a eye-gaze picture of a patient's eye recording the limitation of extraocular movement. In a third nerve palsy, the very classical extraocular movement limitation that we can see is a down and out eye. Let's focus at the center picture here where the arrow is. At the primary position of the eye, what we can observe here is there is left eye ptosis covering the visual axis. And underneath the eyelid, the ptotic eyelid, you can actually see the eye appears to be inferior, meaning down and out, deviated down and out. And when the right eye is observing right front. On the right lateral gaze here, you can see when the right eye is looking at right, the left eye doesn't move at all. There is limitation of adduction noted over the left eye. Followed by the up gaze picture, left eye remain unchanged. There is this limitation seen over the elevation. And here you go. When the patient is looking down, the left eye appears to be more deviated laterally rather than down straight. There is limitation of depression, but the eye is pulling laterally by the so-called intact lateral rectus muscle. That's why the eyes appears to be out. And here again, on right upper gaze, the left eye remain unchanged. So this is what we call the classical extraocular movement limitation seen in third nerve palsy. And having said so, not all third nerve palsy will present classically like this. So it's all depending on the degree of damage that we can see towards the third nerve. And hence, comes this classification known as complete third nerve palsy as well as partial third nerve palsy. In complete third nerve palsy, you will get complete ptosis of the eyelid together with full-blown deviation of the eye, where the eye appears to be down and out. Whereas in partial third nerve palsy, they affect to varying degrees any of the functions of the third nerve itself, meaning that you may experience some limitation of adduction, but your superior gaze and depression is still normal. It could be a partial third nerve palsy. So next, how do we so-called record and also diagnose the degree of limitation in extraocular movement? Here you go. This is the hash charting, which is commonly used in eye clinic for diagnostic purpose to measure the deviation as well as the amount of underaction and overaction of the extraocular muscle when there is limitation. And it is also done for the purpose of record and comparison to look for any improvement or deterioration when patient comes for follow-up. So what we can see here, there are two fields noted in this hash chart, and the smaller field on your right indicates the pathological eye. So in this chart, right eye has the smaller fields, and hence the pathological eye is right eye. From this chart, what we can see, the lateral rectus here, the function is full. There is underaction of medial rectus, superior rectus, and inferior rectus, accompanied by overaction of fellow eye, the left eye, overaction of all lateral rectus, superior and inferior rectus muscle. Hence, from this hash chart, we can conclude that the patient is having right eye third nerve palsy. So what are the commonest etiologies that we can see that can cause acquired third nerve palsy? Vascular ischemia being the commonest cause can be due to uncontrolled diabetes and hypertension, followed by trauma. We could have intracranial neoplasm, mass, hemorrhage, congenital cause, or even idiopathic. From this journal itself, Keynes has analyzed 1,400 patients with tetral palsy and reported that tetral palsy was seen bilateral in 11% of the cases, complete in 33%, isolated in 36%, and associated with recurrent cranial neuropathies in 7%. The causes were reported as commonly trauma, contribute to 26% of the causes, followed by tumor, diabetes, aneurysm, surgery, stroke, and infection. It's interesting to note that out of 234 patients with diabetes, microvascular ischemia was the cause of third nerve in only 2/3 of the cases. And 53% of those with diabetic microvascular ischemia had pupillary involvement and often bilaterally, suggesting a concomitant autonomic neuropathy in this case. And also note here, only 2% of aneurysms spare the pupil. This is the reason why the previous classification of surgical and medical cause is not well or broadly used currently, because not all the ischemic third nerve palsy will spare the pupil and not all the compressive third nerve will involve the pupil. And Chen et al. Has also reported the similar result and case on third nerve palsy. They found out that the most common cause of acquired third nerve were presumed microvascular, 42%, followed by trauma, compression from neoplasm, post-neurosurgical, and compression from aneurysm. And again, they proved that 10 patients with microvascular third nerve had pupil involvement, while pupil involvement was only seen in 64% with compressive third nerve. It's not 100%. Great, let's move on to case-based discussion now. This is the first case that we are going to see. Mr. K, an 84-year-old gentleman, no medical illness. He was diagnosed of having shingles and was started on oral acyclovir 800 mg 5 times a day by family medicine team. He was referred to us initially to rule out right eye herpes zoster ophthalmicus. On presentation, what we can see is there was this vesicular rashes seen along the ophthalmic division of the trigeminal nerve. However, Hutchinson sign was absent. All other cranial nerve function was intact with no neurological deficits systematically. So what is Hutchinson sign here? Very brief explanation. What you can see is there is this rashes seen at the tip of the nose. And when this is present, this is a very strong predictor of the ocular complication of herpes zoster ophthalmicus, because the nasociliary branch of the trigeminal nerve innervates both the cornea, lateral dorsum, and tip of the nose. And true enough, during the assessment, the first assessment, the patient has got no Hutchinson sign, and hence the cornea is clear. 2 days later, he came back with sudden onset of binocular diplopia and ptosis. On ocular examination, there were right eye partial ptosis with restricted adduction and elevation. Pupils were spared. So from the examination, we can conclude that the patient having right eye pupil sparing partial third nerve palsy. As cranial nerve palsy caused by herpes zoster are relatively rare, and looking into the high-risk patient that is having, and patient is old, we actually proceed with urgent contrasted computed tomography of the brain and orbit. There is no radiological evidence of meningitis, space-occupying lesion, and cerebral aneurysm, and hence we treat the patient as right eye partial third nerve palsy, pupil sparing, secondary to herpes zoster. Bachman and Harton has reported a case of herpes zoster ophthalmicus-induced ocular motor nerve palsy. From the report, gathering the literature review, they actually find out that ocular complications occur in 50% of HZO cases and typically fall into 4 categories, being keratitis, iritis, muscle palsy, and optic neuritis. The total incidence of extraocular muscle palsy is approximately 13% being reported, and the third nerve is the most commonly involved. The onset of herpes zoster-induced ophthalmoplegia occurs 9.5 days after the onset of the HZO rash in 75% of the cases. So next, Madam S, the second case here, Madam S, a 72-year-old lady with underlying hypercholesterolemia, hypertension, and ischemic heart disease, presented to emergency for 2 days history of left droopy eyelids associated with generalized headache, vomiting, and neck pain for 4 days. So at presentation, the blood pressure was 199/88 millimeter mercury. An initial urgent plain CT of the brain ruled out signs of space-occupying lesion as well as intracranial hemorrhage. She was then referred to us for eye assessment for left eye complete ptosis. Look at this 9-gauge picture of the patient. The most obvious finding noted at the primary position when the patient is looking upright, the left eye, there was complete ptosis covering the visual axis. Upon looking right gaze again here, the left eye appears to be static. There is limitation of adduction seen, as well as elevation here, depression, and right up gaze. The pupil were anyhow spare at that moment, is reactive and equal. There was no anisocoria. However, this patient complained of having persistent headache, even though the blood pressure is coming downtrend in emergency department. Hence, we admitted the patient to ward for close observation. The next day, when we assess the patient, there is still no pupil involvement, but the headache is very prominent. We then proceed with a CT angiogram to rule out possible aneurysm or actual arterial venous malformation for this case. And true enough, the CTA reviewed PCOM. The patient was actually referred to interventional radiologist for urgent cerebral angiogram followed by coiling. This is the cerebral angiogram taken for this patient. The most obvious finding here was the presence of PCOM aneurysm. At the same setting, we proceed with coiling for this patient, and she recovered well 2 months after the coiling with residual partial ptosis and limitation in extraocular movement. So let's move on to case 3. Mr. C, a 20-year-old Chinese student, presented with acute onset of diplopia upon awakening from sleep for 4 days. There is no history of trauma. He denied of having any headache, nausea, and vomiting as well. On presentation, this is a 9-gaze picture. The most obvious finding at the primary position was not the ptosis anymore, just a little lateral deviation noted over the right eye when the left eye is looking straight. And the extraocular movement, there is only slight limitation noted over the right superior gaze as compared to the left eye when the patient is looking up. Otherwise, adduction is still pretty normal and depression is slightly off, -1 here. There is no ptosis, no mass noted, no history of any other injury being complained of. So this patient has got sudden onset of diplopia, and looking into young age, there is a likelihood of getting very aneurysm, which is very asymptomatic at presentation. So for this patient, we actually proceed with urgent CTA and MRA. However, the CTA and MRA show that there is no evidence of intracranial aneurysm and has also ruled out berry aneurysm, which was previously commonly asymptomatic. So that this patient we actually treat for partial ocular motor nerve palsy with pupil sparing, secondary to presumed viral infection. And this reported case has been shown that viral mononeuritis is not uncommon. It's just that it's rarely seen, and the comprehensive guideline for management and outcome are very difficult to get. And anyway, the patient improved in terms of extraocular movement limitation 2 weeks after the onset, with no residual neural deficit seen. Let's move on to the last case here today. Madam I, a 33-year-old Indonesian lady who was brought in by ambulance after a motor vehicle accident. She was a motorbike rider being knocked by a car when she rode past the red light, and she was thrown from the motorbike and fell on the road with helmet on. She lost her consciousness and sustained ENT bleed. She also has acute right frontotemporal subarynoid hemorrhage and hemopneumothorax and lung contusion on admission, with multiple rib fractures, clavicular and scapular fracture as well. This is the initial CT scan done in emergency department showing right frontotemporal subarachnoid hemorrhage. She was then referred to eye for eye assessment, having said that there is left eye complete ptosis. And when we are seeing the patient, this is the night gaze picture that we see. From the primary position, what we can see here is the left eye complete ptosis covering the visual axis when the right eye is looking up straight. And there is limitation of superior gaze as well as depression here. When the patient is looking right side, right down, the left eye failed to adapt and failed to depress. And this patient, the left eye pupil probably is not so well here. From this superior gaze that you can see, the left eye pupil is actually slightly dilated as compared to the right eye. Right eye pupil is not so prominent. The left eye pupil reactivity is sluggish, but there is no relative afferent pupillary defect seen. Hence, from the assessment, initial assessment, we conclude that the patient having left eye pupil involving partial third nerve palsy, because at this right gaze, the left eye appears to be full, the adduction. Hence, we conclude that this is a partial third nerve palsy, but with pupil involvement. Since the urgent CT scan on initial assessment show no evidence of space occupying lesion with only right frontal temporal hemorrhage, we admitted the patient and observed the patient closely in ward. A repeated CT scan was done for her to assess the resolution of subarachnoid bleed 48 hours after the accident. And the CT scan shows that there is resolving hemorrhage with no new onset of intracranial bleed. So this patient, we actually observed her 2 months after the discharge. We noted that the ptosis as well as extraocular movement has improved fully. However, the left eye pupil remained dilated at 5 mm. So retrospectively, the diagnosis was revised for this case as left eye actually is pupil sparing third nerve palsy with traumatic mydriasis. Later, I will explain a little on traumatic mydriasis. So how common is traumatic oculomotor nerve palsy? The incidence of primary traumatic oculomotor nerve palsy was being reported by Kim in craniocerebral trauma, approximately 1.2%. And the underlying pathophysiology will be damage either directly as a result of the injury or indirectly due to the compression from an expanding extradural or subdural hematoma. And also in this case report, case series discussion, they found out that direct avulsion from the mesencephalon, primary contusion necrosis or intracranial and perineural hemorrhage can also cause direct third nerve injury, especially in the subarachnoid space. So for this patient, we revise the diagnosis to be a traumatic mydriasis due to the dilated pupil remain unchanged when the ptosis and exotropia improved 2 months after the accident. So traumatic mydriasis is actually caused by the direct blunt trauma to the sphincter muscle of the iris, causing the impaired pupillary constriction. The pupil will remain dilated and may not get fully recovery even after months of the accident. So here are the 4 cases of isolated third nerve palsy caused by different etiologies that we have discussed and under our care. So the take-home messages for this session will be third nerve palsy with pupil involvement warrants an urgent referral and detailed neuroimaging to rule out life-threatening causes such as PCOM, intracranial mass or space-occupying lesion. And pupil-sparing third nerve cannot rule out surgical cause, and the assessment should be correlated clinically to look for signs and symptoms that may suggest intracranial pathology. As in our second case, the patient with PCOM doesn't have any pupil involvement and is just due to the persistent headache that we actually asked for a CTA and MRA. Partial third nerve palsy with or without pupil involvement should be followed up closely to look for evolving changes because it can be the early presentation of a pupil involved or a surgical caused third nerve palsy. So in short, not all ischemic third nerve are pupil spared and not all the compressive are pupil involving. I would like to acknowledge Dr. Penny Lord for supervising me into writing this case series for publication. And thank you for your attention.
Okay, thank you very much for the wonderful presentation, Dr. Lim. So I bet she did a good job at refreshing our memory on this important topic. Okay, and also congratulations to the publication of the case series. Yeah, well done to your team. So if you have any questions, please type it out on the Q&A box down below, and I will try my best to answer all of them, okay? So I think I would not delay my session. I would like to call Prof. Sharmilla from Psychological Medicine to moderate the next presentation. Thank you very much.
Very good morning to everyone. I'm Associate Professor Sharmilla from the Department of Psychological Medicine. I would firstly like to thank Dr. Lim Yi Wen for her very interesting presentation. Now I would like to present to you Dr. Fatin, who's a psychiatrist in our department and also my colleague. She will be presenting about behavioral difficulties in children. Can you please join me in welcoming her?
Okay, thank you, Prof. Sharmilla, for the kind introduction. Assalamualaikum and good morning, everyone. I'm Fatin from Psychiatry. I'm currently doing attachment in the Child and Adolescent Psychiatry Unit at our Department of Psychological Medicine. Today, my topic will be on understanding behavior difficulties in children. Okay, so before I start, the reason why I choose this topic is because I believe that when we talk about mental health, we tend to focus more on the adult population, I guess, especially now where during the pandemic we hear an alarming rate of suicide, right, and mental health issues like depression and anxiety among the adult population. However, statistically, there is also a significant increase in the prevalence of mental health issues among the children and adolescents as well. And in the clinical setting here in UMMC, particularly, we do see a surge of these cases during the pandemic. Be it outpatient or as well as inpatient. You know, we see cases like depression and suicidal attempts where we have to admit them in our ward. So, but having said that, even before the pandemic, there are already cases like this among this very young group of people. But these issues were most of the time undetected or overlooked. Most likely due to the complexity of the presentations, because as we know, children, they think and behave differently than adults. Okay, so my talk today will be on how we as adults, as clinicians or as parents ourselves, we can understand the meaning behind our children's behavior in order for us to help them. Okay, so let's start. Okay, so this will be my overview of the talk. We'll talk about the function of behavior, factors influencing behaviors, the type of behavior problems that we can find in children, the common behavioral disorders, and we go deeper into depression and anxiety symptoms in children and adolescents during the COVID-19, and also management of these behavioral disorders. Okay, so why children behave the way they do? So in a way, a child's behavior is an outward manifestation of how he or she thinks, feels, and perceives the world around them. So when talking about human behavior is actually a product of or a consequence of emotion, meaning how they feel, and subsequently the feel is actually a consequence of how they think or what they think. So the pathway is like thinking, emotions, and behavior. So in a way, a child thinks, feels, and behave in a direct manner, right? Rather than adults, actually, which adults tend to be more complex. Sometimes what adults feel, they might not show it in their behavior. Okay, so behavior is a reflection of the children's inner stability and security. So this inner stability and security is in itself actually a reflection of the attachment levels that they have with their parental figures. Okay, so what do you mean by attachment? For example, strong and secure attachment will reflect a more stability in terms of the sense of self, and vice versa. So it is through this lens that we can understand the children's inner world. So the function of behavior, why they behave like that? Behavior occurs because it serves as a function and produces an outcome. So in children, behavior is a form of communication. It's the only effective way that they can communicate with their peers, with the adults. So it's essential that we take a step back and we attempt to understand the reason for this behavior, the perspective of the child, in order to understand their inner world. And according to a systematic review and meta-analysis done in 2020, global prevalence of common mental health disorders in adolescents is 25%, so it's actually quite high. So next we go to the common behavioral disorders. I will explain one by one later. First, we have ADHD, then the oppositional defiant disorder, or ODD, conduct disorder. We have intellectual disabilities, learning disabilities, autism spectrum disorder, depression, anxiety, and lastly, internet addiction. So we go through this one by one briefly. So before that, we talked about the function of behavior. Now we go into the factors that influence these behaviors. So first is the temperament of the child. Temperament means a collection of an innate psychophysiological characteristics which differs in every child. So what does it mean actually? So this collection of these characteristics is actually attributed to the genetic and environmental effects on a child's development of the personality. So researchers, they identified that temperament is as a spectrum ranging from an easy child at one end and a difficult child at the other end. Okay, so studies have shown that through this spectrum, 10% of children can be identified as difficult child. Difficult child, for example, they very difficult to comfort, they react intensely to stimuli, they cry easily, it's very hard to be to comfort them. They have a hyper alert physiological makeup. And 40% can be identified as easy child. So easy child means they have more regular sleeping and eating habits. They're more flexible, they can adapt to new stimuli better. They have minimal distress and are easily comforted. And the other 50% is a mixture of these two types. Okay. So next one is the parenting styles. So studies have shown that low levels of sensitive parenting and greater use of harsh discipline have been linked to the development of behavioral problems. The so-called negative parenting styles that are identified are authoritarian, neglect, and permissive. So authoritarian parenting is characterized by overcritical parents, lack of warmth, being too strict, and having inflexible rules. Sometimes they practice punitive punishment as well. So this may result in children having low self-esteem, unhappiness, social withdrawal. Neglect is when there is a non-involvement, as the name implies, non-involvement in the child's life and rearing, and this usually will cause an impaired children with impaired self-control and increased risk of aggression. And permissive parenting, usually there is a little or no limit setting by the parents, but it can sometimes be unpredictable parent harshness as well. So this will usually result in children with low self-reliance, poor impulse control, and aggression as well. So the other factors is environmental causes, more of like a psychological causes, such as family unit, communication problem at home, a chaotic home environment, parent-child difficulties. And important to note that adverse life events like loss of parent or separation, divorce, abuse, this can also this can also influence the behavior in children. And lastly, psychiatric disorders. Definitely, if a child has a psychiatric disorder, that would definitely influence the behavior. Okay. We look into more detail on the parent-child difficulties just a little bit. So what do you mean by parent-child difficulties? These are the example. First is the family disruption. So in some families, they can have separation, divorce, parents remarry, having step families. So that can be a factor that can influence the child's mental health as well. Poor couple functioning occurs when there is marital discord, be it acute or chronic, between the parents. Any arguments or fights in front of the children. Parents displacing their anger on children, that would definitely affect the child's mental health. Parenting distress when there is opposing parenting styles. One parent can be authoritarian, or another parent can be permissive, or even an absent parent. So there can be confusion in the home environment and the rearing style for the child. So that can be confusing and definitely will affect the child's mental health. Okay, so next is the maternal psychopathology. Studies have shown that if a parent, especially the mother, is depressed or anxious, most likely the child will have a higher risk to get depression and anxiety as well. Okay, so it depends on the maternal psychopathology. And lastly is the lack of support. Definitely, single parent, isolated family, that would definitely affect the mental health as well. So all these factors influence our child's behaviors and can be a risk factor for the child's mental health issues. Okay. So next we go to the type of behavior problems that the child exhibits. So there are two types, which are the externalizing behaviors and internalizing behaviors. Let's go look into it one by one. Externalizing behaviors is a group of behavior problems that are manifested in children outward behavior. So meaning it reflects the child negatively on the external or physical environment. So this usually consists of disruptive, hyperactive, and aggressive behaviors. Examples are defiance, impulsivity, hyperactivity, aggression, stealing, lying, and even sexual disinhibition like promiscuity. So all these are outward negative behavior. And studies have shown that childhood aggression is a strong predictor of adult crime and violence. So next we go to the internalizing behaviors. So this is the opposite of externalizing, as the name implies. These behaviors are directed inward and are indicative of a child's psychological and emotional state. So the internalizing behaviors, examples are social withdrawal, depression, anxiety, even somatic complaints. Some children, they tend to internalize their emotions, and they can manifest through somatic complaints like headaches or stomach ache. But of course, they do this unconsciously. Okay, and avoidance behaviors is also as a form of internalizing. Okay, so let's go to the common behavioral disorders in children. First is ADHD, which is attention deficit hyperactivity disorder. This is actually a condition that makes it difficult, for an easier term to understand, is a condition that makes it difficult for children to pay attention and or control their behaviors. Okay, so common scenarios, because nowadays we know there's an increased awareness of ADHD among parents, among school teachers. But then the common scenarios usually by them is, okay, the child is lazy, always daydreaming, sleeping in class, the child is not interested in studying, child is stubborn, child is difficult, naughty child. We hear this a lot from parents or from teachers, counselors. I don't think the child has ADHD, or he or she is not hyper, he or she is not running around. So they don't think it's ADHD just because the child is not hyper and not running around. Or sometimes we hear the child is messy and often forgetful. So these are the common scenarios. When we dig deeper, is actually it could be ADHD. Why so? Okay, so common misunderstanding. Again, many parents may feel that children are best in the mainstream education. Hence, children who are struggling in this mainstream education were often undetected. Okay, when detected, they are often dismissed. It will go away. Usually they will say it's still too early to say. Well, I'm sure the child will pick up soon, like his brother and sister. So this is what the common scenario is. They tend to compare, with the other children, with other siblings. So in ADHD, they have a lot of difficulties in a lot of areas. So one of it is in the learning area, academic. So in school, children with ADHD, they actually struggle with academic performance because of their um, inability to maintain focus, right? They have a very short attention span. So in school, they struggle with academic performance. So they do not do their work, could not complete or submit their work. They cannot work on their own, and they need almost always need help or guidance with finishing their work. So when exam comes, so they usually fail the exam, they could not perform consistently, and if there is no guidance or reminders, the child would not be seen doing homework on their own. And hence they're often as labeled as lazy or not interested in studying. Other aspect of behavior also, why children with ADHD can also be seen as having behavior problems or bad attitude. Due to the child having difficulties, they struggle with education, they tend to gravitate towards indulgent and pleasurable activities, easy activities such as truancy, fighting, bullying, vandalism. So often what is seen by adults are just these behaviors. So they would be labeled as naughty, delinquent. But what is missed is the underlying core difficulty of the child. Okay. So in a nutshell, in reality, it is in a case or a scenario of ADHD or sometimes learning disabilities, because studies show that ADHD children, they have a certain percentage of learning disabilities as well. So they struggle at school, they struggle at home, they became disinterested in studies because they know they cannot cope, right? They are unable to handle the stress and expectations of the parents, of the teachers. So they became uncooperative. They became in layman's word, rebellious, and they're uncooperative at school, uncooperative at home. They become defiant with the teachers and parents. So then this gives rise to a more behavior difficulties like depression, anxiety, anger, aggression, and so on. Okay, so this is a very good example of the behavior which comes from the difficulties that they were having emotionally. So it manifests in an outward behavior. Okay, so if all these difficulties are left untreated, okay, children with ADHD can develop ODD or oppositional defiant disorder. This is a pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness exhibited during interaction with at least one individual who is not a sibling. This is a criteria to diagnose, actually, according to our manual. Sorry. Okay. So symptoms of ODD includes the child often loses anger, often touchy or easily annoyed, meaning easily sensitive. They often defies or refuse to comply with adults' requests. They're very defiant. They deliberately annoys people, blames others for the mistakes, often angry and resentful, spiteful and vindictive. Okay, and if further left untreated, subsequently they may develop into another disorder called conduct disorder. So conduct disorder, where the child's behavior is characterized by aggressive and destructive activities that cause disruptions in the child's natural environment, such as home, school, and society. So this is a more extreme spectrum of an aggressive behavior. Okay, so it is a repetitive and persistent pattern of behaviors that violate societal norms and the rights of other people. It can be categorized into 4 types. First is the aggression to people or animals, like lying, bullying, fighting, torturing animals. Second is destruction of property, like vandalism, setting fires, deceitfulness or of theft, stealing, breaking into people's houses, often lies or cons others. And lastly is the serious rule violations like truancy, staying out at night despite parental prohibition, and running away from home. And according to our manual for diagnostic criteria, usually this occurs less than 13 years of age. Okay, so next we go to autism spectrum disorder and violence. So autism is a range of it is a spectrum, is a range of complex neurodevelopmental disorders characterized by social impairments, communication difficulties, and restricted, repetitive, and stereotype patterns of behavior. And 1/3 of ASD children exhibits intellectual disabilities as well, or learning disabilities. Okay, so children with ASD are exposed to various types of violence due to the wide range of disabilities, especially the social communication difficulties. So aggression or violence is usually a result of third variables, rather than due to the ASD itself. So what are the third variables? Usually includes poor parental control, family environment, bullying, or psychiatric comorbidities. Okay, so these behaviors often cause a great deal of difficulty for the families. Usually they would hit, kick, bite, throw objects, and other self-injurious behaviors like hitting themselves, hitting the head on the wall. So this can greatly increase parent stress. They become easily aggressive when adults interfere with the repetitive behavior. When someone tries to take away an item, that they need to continue a repetitive routine, because we know that autistic children, they're very fixed with their routine, right? Or when they are trying to escape an uncomfortable sensory input, because they have a certain increase in heightened hypersensitivity. Yeah. So as they grow older, the behavior difficulties that they can have in ASD is all this, including depressed mood or irritability. They have low self-esteem, difficulty in forming a peer group. They have emotional dysregulation. They become easily angry, easily sensitive. They have maladaptive ways of coping, like self-harm behaviors. They tend to have internet addiction, drug abuse, and of course, becoming more recluse, social isolation. Okay, so next is intellectual disability. In the past, the what do you call this? It is used to be called as mental retardation, but we don't use that term anymore. Now we use intellectual disability. Okay, it sounds better. So it's characterized by significant limitations in both intellectual functioning and adaptive behavior. So the intellectual functioning includes the reasoning, learning, and problem solving. Adaptive behavior is a conceptual, social, and practical domain. Okay, and the more severe the level of intellectual disability, the higher the risk of coexisting psychiatric disorders. Disruptive and conduct behaviors occur more in mild to moderate ID. They also have high incidence of depression and psychosis, and due to the experience of repeated failures in school, they develop negative self-image, low self-esteem. And whereas those with severe ID are more likely to meet criteria for autism and exhibit symptoms of self-mutilation, self-injurious behavior. And depression in these children was usually associated with screaming and aggression. Is more of an externalizing behavior. Next is learning disabilities. Learning disabilities is referring to a specific learning rather than an intellectual global disability. So this includes language and speech, as well as specific learning like reading, writing, and mathematics. 25 to 55% of children with learning disabilities have behavior problems, and these include aggression, delinquency, excess consumption of activity, non-interaction, and sleep for short periods. They also have emotional problems, like thinking, processing problems. They have attention deficit, so they can sometimes exhibit ADHD symptoms as well. They have poor concentration, low self-esteem, sadness, emotion, confusion. And due to these processing problems, they usually have issues with social behavior. They find it difficult to pick up social cues, which results in avoidance behavior. So in our clinical settings, this avoidance behavior, children usually present with school refusal or school truancy. And often they have these underlying learning disabilities. Okay, so next we go to depression. Okay, so depression in children and adolescents can be challenging to detect, as presentations usually differ than depression in adults. So sometimes it can be overlooked. Okay, so but there are some overlapping symptoms with adults. So let's see what we can detect in our children. So first is avoidance and withdrawal. Children with depression, they may avoid everyday or enjoyable activities and responsibilities. They may withdraw from friends and family. Bedroom can become a favorite place to escape and find solitude. They can be clinging and demanding. They may become more dependent on some relationships. For example, adolescents, they have boyfriends or girlfriends, so they can be more clingy. They behave with an exaggerated sense of insecurity. They can have activities in excess. Sometimes can be out of control in regard to certain activities, such as video games, or even binge eating. They may spend long hours on these activities. So they can have restlessness. The restlessness brought on by depression may lead to, behaviors such as fidgeting, acting up in class, or reckless behavior. Self-harm is important to note that, these depressed individuals may cause themselves physical pain, take excessive risks. Usually, the most common presentation can be, self-cutting, overdosing. They have difficulty in organizing their thoughts. People with depression often have problems like concentrating or remembering. In children, this may be evidenced by problems in school or inability to complete tasks. They have a very negative view. They become very pessimistic. They perceive themselves, their life, and the world in a very negative light. And they have worthlessness and guilt. They may obsess over their perceived faults and failures. They feel tremendous guilt and declare themselves worthless. They have helplessness and hopelessness. Okay, they often believe that there's nothing they can do to relieve these feelings of depression. And they have feelings of isolation. They become very sensitive by comments and remarks, and feel as if they are abandoned. And lastly, they have suicidal thoughts of death, searching ways to end their life. Let's look a little bit into the depression and anxiety symptoms in children and adolescents during the COVID-19. Okay, so prior to the pandemic, the rates of depression and anxiety symptoms among large youth cohorts were 11.6 and 12.9% respectively. Okay, so it's 7% of depression, 12% of anxiety. However, the rates increased to 25% in depression and 20% in anxiety during the first year of the pandemic alone. So we see a surge rise there, and the prevalence are found to be higher in studies collected later on in the pandemic, and as well as in girls. Meanwhile, the depressive symptoms were higher in older children. So factors that were identified in the studies is usually the pervasive social isolation, school closures, they are forced to stay at home, some of them may miss milestones, increased family stress, decreased peer interaction. So those are the factors that are identified to cause all this. For anxiety, usually they will present with uncontrollable worry or fear or hyperarousal. These children, they tend to have concerns for health and well-being of the family, causing uncertainties and disruption in their daily routines. Okay, so lastly, we go to the internet addiction. Actually, it's an emerging condition in this current day and age. Yeah, so this includes social media addiction as well as video game addiction, and is related to cyberbullying as well. And there are many studies done on that nowadays. So it shows that internet addiction is closely related to depression, anxiety in children and adolescents. This relationship can go either way, meaning adolescents with internet addiction who presents with symptoms above, like reclusive, spending hours on end on the internet, gaming or on social networking sites, and have severe agitation when the internet access is withdrawn, and they have blurring sometimes between real and virtual world. These adolescents who presents with all this, they can develop depression, anxiety along the line if not intervened, and vice versa. Adolescents with an existing depression and anxiety from whatever reason, along the course of the illness, they can develop this internet addiction when they use internet as a form of escapism, to escape the harsh reality that they live in. So we see this a lot during the pandemic, where social restrictions have forced them to find solace in the internet, especially those that live in a chaotic home environment. So internet can be a source of distraction for them. Okay, so how to manage all these behavioral disorders? Okay, so we usually have to address the underlying disorder, right? Behaviors are just the tip of the iceberg. Like I mentioned in the earlier part, behavior is a consequence of emotion, which is a consequence of thinking. So detection is important to know when to seek help. Communications with school are essential, liaising with teachers, counselors. Here we do a lot of parent work, treating the parent, treat the parent, then treat the children. And parenting skills as well. Also individual work with the child, especially in adolescents. We have group therapy, occupational therapy, and also medication. Okay, so as parents, what can we do, right? So parents and teachers are usually frontliners, and change needs to start with us. Always look at the child holistically. Children always behave a certain way for a reason, and behavioral difficulties in children are always due to a multitude of factors. Okay, and labeling and pushing the child to do more or work harder does not help usually, as this may worsen the child's behavior. Instead of commenting or scolding or giving instructions, it's essential we must listen attentively, try to understand what is behind the child's behavior, what is the thinking, what is the emotion, support, listen, hear what they're saying, try to make conversations with more open-ended questions. Sometimes, we as parents, we unconsciously want to give advice, or we tend to give instructions, but try to listen and understand, and let them talk. And remember that every child is different. We cannot compare them to others. Okay, and we have to accept that depression is real, ADHD is real, autism is real, and so on. Okay, but having said that, we as parents have to be mindful of our own health as well. A stressful parent can cause a stressful child. Okay, so children who have behavioral disorders mostly have parents who also have internalizing problems. So be mindful of how we talk to other people, how we talk to our children. Children are most likely to mimic our manners and behaviors, especially in social contexts. So if always in doubt or burnout, always seek for help. Right? Okay. So the pain, this is my last slide, the pain and distress that children experience within are much more than the behaviors they exhibit. So always remember that. And thank you so much for your attention. Okay, with that, I've come to the end of my talk. Thank you for your kind attention. I'm sorry to have dragged on a bit. I hope this talk has been somewhat helpful to you all, not just as clinicians, but on a certain level as parents as well. Okay.
Thank you, Dr. Fatin. That was a very interesting and enlightening presentation. Are there any questions?
There are quite a number in the chat box, Prof.
Okay.
Okay, so how do we address that? Can we go to the first one, Prof?
Can you see the question? How do we address
it's in the chat box, Prof.
Society.
The Q&A box.
Yeah.
Oh yeah.
How
do we address ADHD if we see it in society? For example, another person's child that we think may be having ADHD.
And disrupting others.
Oh, and disrupting others. How do you address? Well, if you see another person's child and you think that the child might have ADHD, of course, the first thing to do is to approach the parent or the teacher. Yeah, that would be my advice. If it's going to be easier if you know the parents, the child's parents, but that's how you should do it. I approach the parents, because the parents are the only person who can address this or bring the child to get professional help, or can approach the teacher as well to talk to the parents. Yeah.
Okay, the next question. Looking back as a child, I was often bullied in school. Now that same bullies have become adults and trying to be friends with me, maybe because I'm a doctor or just that everyone has matured. I think they may have had ADHD that developed into conduct or oppressive disorder. How should this be addressed if it happens today? The bullying part, as some parents may not take suggestions or advice from another parent well.
Yeah, so these are the difficulties that the societies face, because definitely you cannot bypass the parent. get help. So the only I would say way that you can do it is either parent or teacher, yeah, or even another family member that that you know well, rather than the parent, that you know would probably talk to the parents um and get the parents to get help for the child. Yeah.
Okay, the next question. I find the biggest challenge after a child being identified of potential behavioral issues or intellectual disability is it just skipped.
Yeah, it keeps moving.
Is the availability of channels to seek for proper assessment and help. The appointment from government service can be as long as 12 to 18 months, and private service costs a fortune.
Okay, identified.
Actually, what is written here is correct.
Yeah, it is. It is.
There are
Yeah.
too few child psychiatrists, I guess. But the
So that's our limitation. Yes. Even if you thought in UMFC the waiting list is very long as well. But we do cater acute cases here. So if in any acute cases, we always tell them to come to the emergency service rather than to take an outpatient service. Yeah.
Are there any community resources to address these issues in children who cannot access tertiary facilities, especially since child psychology services are so limited in the public healthcare?
Okay, so we do reach out to, we do educate the school counselors in schools. So they should be able to actually detect or help with these issues at the frontline level before seeking the professional help. Yeah, so that's what we do. We do have this education programs to school teachers and counselors, so they can be the frontline detector for these children in school. Yeah.
To the next question. How do we get affected adolescents to access medical care if they refuse to cooperate? Physically bundling them to care is not as easy when compared to the process when they are young.
Where's the question again?
YK.
Um,
How do we get affected adolescents to access medical care if they refuse?
okay, yeah, so this is actually this implies to all psychiatric patients, not just adolescents. It's always a question of, how to bring them to medical care when they cooperate. But if you find that it's up to the level of when you concern for the safety of themselves or safety of others, you have to bring them in physically. That's what we usually do, right, Prof? Yeah.
Sorry?
Uncooperative patients, this implies to all psychiatric patients, not just adolescents, even adults, when we know that they need psychiatric help, but they don't want to come in. The only way that we can do is to get them physically in if we feel that they are at risk to themselves or risk to others. Yeah.
Also, it depends on the case. Like if it's a case of depression, if the child is rational, you can explain to the child how this behavior is going to affect the future. So if they understand that what's the reason that they need help, then they might be more amenable to coming in. But if the child has a psychotic condition or something else, then probably you need help of multiple people to bundle them to the hospital.
Yeah.
Okay, so coming to the last question, our teachers and academic staff at school don't seem well educated in this area. They regard students with potential problems as troublemakers or hopeless candidates rather than assisting in seeking appropriate help. What can be done from our side as healthcare professionals to improve this?
Yeah, so that's why this is the thing that I mentioned just now. We do have programs, but because of our own limited resources, it's how far that we can reach. We do try to do that. a few times per year actually. We organize all this. So I guess we in the first place we need to increase our number first, so that we can impart our knowledge to all these children, these teachers and counselors at school. Because this thing is so vast, it's difficult to reach out in the community. But yes, it's something in progress. Yeah.
Okay, there are no more questions. So I thank everybody for joining us this morning. And thank you again, Dr. Fatin and Dr.
Thank you, Prof. Okay, thank you everyone.
Fadhilah.
Have a good day.